ladies and gentlemen, and welcome back as we continue our program here on M42's main stage at the inaugural Abu Dhabi Global Healthcare Week. This is day 2. We already kicked off with some very exciting sessions this morning. Now, we are going to be looking at in this particular session, sharing with you the current thinking and planning when we speak about genomic screening. And to take us through this, to explore this fascinating subject area, we have 2 gentlemen. I'll introduce them both. Joining us first on stage is Dr. Mohammed El Amiri, who is the Department of Health, Abu Dhabi's Section Head Studies and Special Projects. And then later joining him on stage will be Dr. Lawrence Petalidis, who is Head of Global Partnerships, M42. So please give a big warm welcome to Dr. Mohammed, who's coming on stage first. You can steal. Absolutely. And over to you, Dr. Mohammed. This is a very exciting time. Thank you so much for taking the time out of your busy schedule. You were here with us yesterday.
Yes.
And as Department of Health, these particular events, they're very important, are they?
Yes, they are. They are, especially while engaging with our stakeholders. One of the main stakeholders, M42. So.
Fantastic. Well, thank you so much. And over to you.
Thank you very much. Assalamu alaikum, everyone. My name is Mohammed Al Amri, and I'm the section head of subjects at Department of Health. Can you hear me? It's good. Oh, good. Perfect. So today we want to convince you on why we're planning on genomic screening within the population of Abu Dhabi. So in the UAE, we look at genomics as a lifelong journey. So we look at it from premarital screening. So before even the Emirati, let's say, person gets born. So with the premarital screening, we look at how can we find couples that are compatible with each other genomically, so that when they have their offspring, we are sure that they're not going to pass on any genomic disorders. So after that, what we look at is newborn screening. So we've got that part covered, the premarital screening. Now we go with the pure newborn screening, where we look at actionable diseases rather than diseases that are passed on. So with actionable diseases, if we find anything using whole genome sequencing, we will identify that mutation, and we will notify the parents that, yes, your child might have this, but we have actions on it. We can give you the therapy, or you can do some like any actions like different diet or different habits. After that comes the genomic screening, which we're planning and we're thinking of. I'm going to delve into the genomic screening afterwards, but I'm going to tell you on what we're doing at the moment. So at the moment, we're working on lifestyle and wellness programs for every Emirati that joined the EJP. So there's a report that tells them all about their wellness, their diets, anything that would make them live a healthy lifestyle. And afterwards is the clinical genomics. So we already have personalized and precision medicine programs implemented, especially for oncology and also cardiovascular diseases, where we look at the genes that are responsible for those diseases and look at the siblings of those patients to see if there's any predisposition of those cancers as well. Afterwards is the pharmacogenomics program, and this is a very niche program that we have in Abu Dhabi, and inshallah it will be in every patient's health record very, very soon, where we have a pharmacogenomics report, and so they know exactly what kind of medication works for them and what doesn't. And lastly, somatic testing. So somatic testing, as you know, for oncology, this is something that is currently in the pipeline. We do have some somatic testing, but we want to have whole genome somatic testing, and that's as you all know, it's a bit of a challenge, but we're pushing for it, and inshallah very soon we'll have it ready. So back to genomic screening. So as you all know, the UAE has 100% whole genome sequencing based at M42 as the operational arm of this program. And we've sequenced more than 500,000 genomes. Compared to others, like let's say in the States, they have All of Us program. Not all the program is whole genome sequenced. However, they have a big database. Also, there's the NHS, which is 100% whole genome sequencing, and they've also sequenced around 500,000 genomes as well. And there's also Precise at Singapore. It's the precision medicine program where they sequenced 10K so far, but they're aiming for 100,000 now. And then the Chinese Millennium database. So far, they've sequenced around 140,000. However, they're aiming for a million program. So, and now it's back to the convincing part. So the UAE population will enable the first global first genomic screening initiative, where we look at it from a genome-driven screening, where we look at predispositions, risk identifications of the population before they get the let's say the disease, before they reach that point. So that's the aim of this program. So we want to have a downstream care where basically, if we find any predisposition, we'll tell them to screen more often. We'll have special clinics for them so that they can come to our hospitals and have that healthcare management. So after that, we're going to have confirmatory diagnostics, and also we'll have family risk detection with cascade screening. So looking at the whole family, not only one person, and then all those medical follow-ups that I mentioned, and again, accelerated screening programs. So when we link it to precision medicine, so we have now precision prevention program, and that's the aim for it. So yes, precision medicine is amazing, gene therapy is amazing. However, prevention is even more important because that's going to stop us from getting there. So we look at it from population genomics. We screen those population. We look at that. We downstream risk management of those that we find any predispositions for. Then that's the prevention part, and then goes back again in the same cycle. So we're looking at different specialties like oncology, cardiology, neurology, congenital abnormalities. However, we're focusing now on 3 big, well understood and highly actionable diseases. So the first one is inherited cancers. As you know, there's an alarming increase in incidence in cancer in 20 to 49 years old Emiratis. And with cancers, there are some genes that we already know that can carry, let's say, a predisposition of certain cancers similar to BRCA1 and BRCA2 within the Emirati population that may lead them to breast or ovarian cancer. And this is why inherited cancer was one of the most important ones. Next is the familial hypercholesterolemia. So 50% of familial hypercholesterolemia patients have a stroke by age 50. So, and this is why this is very, very important. So we're looking at those genes that are only actionable that we can find within the Emirati genome, so that we can detect it, and then we have we increase the screening time. We decrease, the screening time of those patients. Well, not patients yet, participants, before they basically get to that point where they can go back. And lastly, monogenic diabetes mellitus. Monogenic diabetes, so type 1, and type 1 and type 2. So basically, type 1. So we're looking at MODY genes. Those MODY genes are usually in teenagers. So basically, when we pinpoint those MODY genes, we can tell that this patient, they say, can have better treatment. Let's say, without misdiagnosing them. And this is the most important part of this. So inshallah, in the future, we're going to increase more genes as soon as we, let's say, validate them from literatures. So now I want to show you what genomic screening can do from previous studies. So this is a US snapshot of cancer. So you can see that they did the screening. They saw that, let's say, a lot of them have risk by age 80 with this mutation, so BRCA1. So all of them had frequent screening, and with frequent screening, as soon as they develop cancer, they can get treated, and almost all of them actually get treated afterwards, rather than waiting later on. And from the UAE, from Abu Dhabi, when we did the personalized medicine program at the Cleveland Clinic, Abu Dhabi, we saw that most Emiratis actually have either BRCA1, BRCA2, or RAD50. So this is different than the Western population. So this is something new to us. However, we are trying to now focus on those genes. We're not neglecting the others, but we're putting more focus on those genes than the others because we've seen that it's common here within the population. And with this, I'll introduce Lawrence, Dr. Lawrence. He's going to give you a bit of a brief about the program.
Thank you so much, Mohammed. Thank you so much. Thank you very much, Dr. Mohammed. It was a fantastic introduction. My name is Lawrence. I work for M42. I'm the head of global partnerships, and I have a cancer genomics PhD background, so this is a very, very exciting opportunity for me to share with you some of the work that we've done in preparing our thinking and preparing our planning along with the Department of Health for genomic screening. This slide is a slide that took a lot of time to build. It has, as you can see, a very significant diversity and breadth in expertise, experience, roles, and responsibilities across M42. I want to just note to you the power of this organization that can bring really the data scientist and bioinformatician all the way to the hereditary high-risk clinician and the oncologist and the frontline clinician to the same table to deliver this as a one entity. I would like to just maybe, I think from the audience, just point towards a couple of key stakeholders in this effort, not least Dr. Fawad Khan, who's sitting right there, who's contributed very much with his expertise as a high-risk physician and a leader in Cleveland Clinic, and also Dr. Stephen Grabmeyer, also from the Cleveland Clinic. Somewhere in the back there, you'll find Dr. Tiago Magalhães, who's our director for bioinformatics, who's also very, very central, that good-looking guy right there. And many others. Dr. Azza is here, so I'll move on, but I can't stress enough how much team effort this planning has taken. This is a visualization, again, of the continuum of sort of offerings and capabilities that M42 can bring to the table for this program, starting from big data genomics, going into the bioinformatics, complex bioinformatics that are needed to identify these pathogenic variants and individuals at risk of inherited disease, and then going into the actual screening and report generation, and of course passing at this stage to the clinical arm of the business for downstream assessment, confirmatory diagnostics, clinical genomics, and of course all the high-risk hereditary disease care that Dr. Fawad and his team are leading, and others in the ecosystem, of course. Finally, the M42 and CRO position here, just to note the importance of diagnostics and follow-up diagnostics as part of this journey. This is a quick snapshot of the genes involved for the diseases that Dr. Mohammed mentioned: common cancers, familial hypercholesterolemia, and inherited diabetes. And this is a slide that Dr. Fawad prepared again. It's a beautiful slide. It's a bit complex. It's a bit rich, but it's used here to illustrate an incredibly important point that Dr. Fawad is leading for us, really, which is making sure that what a program like this looks at is very, very actionable. And the color coding that Dr. Fawad has done here, we share the clinical practice guidelines that relate to the specific tumors that are in scope for this exercise. This is a snapshot that Dr. Tiago, our director for bioinformatics, prepared. I'm not expecting you to read it, but it just goes to show the sort of complexity of the bioinformatic workflows for something like this. All done in-house with proprietary technology and knowledge that we have here in Abu Dhabi. Not only M42, but also our ecosystem friends and partners. And this is a snapshot of the detailed downstream clinical care guidelines that need to be applied to a piece like this so that you have a patient flow that is streamlined and a patient experience that is well thought and highly actionable. a key organization from the M42 network that's part of this program. But of course, unfortunately, Dr. Sarah Suleiman, who's leading this from this side, is not here. She's presenting abroad. Is Imperial College London Diabetes Center. Dr. Sarah Suleiman is leading on the familial hypercholesterolemia and inherited diabetes side of the program. And she's a global expert in it. So this piece I don't think we need to go into because it's a bit too detailed and we're kind of running out of time. But I wanted to very quickly show you some of our proprietary tools here at M42 that were presented also in more detail by colleagues this morning that enable this program. Med42 is a large language model that we hope to be able to integrate into this patient-facing experience for patient engagement and patient education. And these are just snapshots of the in-house bioinformatics tools and data analytic tools that a program like this would require. My colleague, Dr. Maz, this morning went through them in quite a bit of detail. I'm sure he's around here in the audience if you wish to ask him any further questions. This includes our clinical data analytics. So I think with this, I'll thank you. It's a privilege to have you here. And again, my thanks to Dr. Mohammed and Al-Bara, Dr. Mohammed and Al-Bara, who are there and are very, very central thinkers of this. Also, Mr. Al-Bara Al-Khani, who's our Senior Vice President for Operations. So please put your hands together for all this team. I'm here representing, with Dr. Mohammed, a very big group of people. Thank you so much. There's a panel on this same topic at 2 o'clock, I believe, today. So questions can be taken also there.